Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Case Review with ASTRO Experts for Ukraine. Today we have a session on prostate cancer, and we are honored to welcome internationally acclaimed radiation oncologist, a visionary in prostate cancer radiotherapy, and this year ASTRO Golden Medalist, Dr. Mac Roach III from University of California, San Francisco. And our Ukrainian speaker today is Dr. Lyudmila Bordiuh. She is a radiation oncologist from Dnipro Cancer Center. So Dr. Roach had a really major impact on the field of radiation oncology. He has more than 30 years of experience, accentuated by numerous firsts and challenges to dogma. He devised the first equation for predicting the risk of lymph node and seminal vesicle involvement that was incorporated in RTOG trials. He led the first large phase 3 trial using PSA as symmetric for outcome. Later, he served as lead author on most widely cited paper defining treatment failures after radiotherapy, Phoenix definition in 2006, which is still the standard today. In the days of 3D conformal radiotherapy, he helped to set standard for defining treatment margins, angles, and fields, as well as defining dose constraints for maximum potency preservation and rectal sparing. He helped write the white paper for the NCI IMRT working group, providing guidance on the use of IMRT in 2001. He was a leader in the routine implementation of gold marker seeds for IGRT for prostate cancer. More recently, he has been involved in pioneering work on sentinel lymph node imaging and the use of salvage radiation for treatment of local recurrences after radiotherapy. He helped develop the first model based on prostate cancer patients treated on phase 3 trials to predict disease-specific overall survival in 2000 and wrote the first paper to show that pre-treatment PSA was predictive of death for prostate cancer in patients treated on phase 3 trials and multi-institutional data in 2000 and 2003. Dr. Roach is best known for his leadership and participation in phase 3 prostate cancer trials. At the completion of RTOG 0924 and RTOG 9413, Dr. Roach would become lead investigator for the largest number of men recruited onto phase 3 trials evaluating radiotherapy for prostate cancer. Dr. Roach also published more than 300 papers, book chapters, editorials, but more importantly, his work really matters, has been very impactful. In addition to serving as a reviewer for many top-notch cancer journals and on several editorial boards, he provided practical recommendations on how men should be simulated and treated for prostate cancer and incorporated these in ACR appropriateness guidelines from 1996 through 2006. He also served on executive committee of the AGCC, continues to be an active contributor in NCCN guidelines for more than 5 years and continues to serve on UICC GU committee. He currently serves on ASTRO International Educational Subcommittee and as a reviewer for GU abstracts for the ASTRO annual meeting. The predilection for first did not start with radiotherapy. He was the first African-American chief resident in medicine, Highland Hospital in Oakland, California. First African-American fellow in medical oncology at University of California, San Francisco, and first African-American to train in radiation oncology at Stanford. He went on to become the first African-American to join the faculty in the Department of Radiation Oncology at UCSF. Dr. Roach has been very active in service to the field of radiotherapy and the underserved. Dr. Roach considers himself as a grassroots community worker. He has volunteered for more than 20 years in community-based cancer control efforts in Oakland and in San Francisco. And he currently serves on the California State Board of American Cancer Society. For his work on cancer outcomes, underserved communities, he received the HealthNet Wellness Award in 1994. He was awarded the first UCSF Community Community Service Award in 2007 and received Sacramento Community Cancer Coalition Award in 2010. He served on the Department of Defense Prostate Cancer Integration Panel, on the NCI Board of Scientific Advisors. In 2012, he was appointed by the President Obama to serve 6 years as the only radiation oncologist on the National Cancer Advisory Board and has been particularly active in the subcommittee on global health and in efforts to improve communication between NCI and cooperative groups. He has received numerous awards, including the first Outstanding Community Service Award in 2007, given the hospital CEO as an honorary doctorate, and the Candle in the Dark Award from his alma mater, Morehouse College, as well as the award from the San Francisco Bay Area 100 Black Men and the Lifetime Achievement Award from the National Organization of 100 Black Men. Welcome, Dr. Roach. And our second speaker is from Ukraine. Her name is Lyudmila Bordiuh. She's a radiation oncologist at Dnipro Regional Cancer Center. She has 7 years of experience in radiation oncology. She's a very active speaker at the national conferences. And this year, she completed the observership at Johns Hopkins in Baltimore, in US, and also at Christie Hospital in Manchester, England, organized by Help Ukraine Group. So very excited for today's prostate cancer lecture. Dr. Roach, thank you for teaching us today. We are very honored. We really appreciate it. The floor is yours.
Well, thank you for that rather lengthy introduction. I guess that was about me. I'm going to talk about radiotherapy for prostate cancer, mostly focusing on hypofractionation and ultra hypofractionation. Excuse me, I'm getting over a cold. So when I started out in the field of radiotherapy, we used to use orthogonal plane X-rays and crayons to design radiation fields for patients. So I've been doing this a very long time, and this was cutting edge at Stanford back in those days. So we've moved as a field a long way, and really things are so much different now than they used to be. So regarding these shorter courses of radiation, which in the old days, we treated people as many as 40 times, so 40 treatments. And now we're down to, I commonly treat people with 4 treatments. Who should be treated with these short courses? How does radiotherapy compare to radical prostatectomy? What are some of the advantages of the shorter courses of treatment? We know cost, we know convenience. How do we define what the standard of care should be? I really don't have time to talk about biomarkers. If the questions come up there, we can talk about things like Decipher, Prostox, and Artera. I don't think they're readily available in Ukraine, but if there's interest, we can talk about those. Those are very important in the modern management of patients. Talk about the use of stereotactic body radiotherapy combined with pelvic nodal radiation, and also the use of hormone therapy. Critical to all forms of radiation is you really need to know the anatomy. So you all know these statistics. These are from last year, close to 35,000 deaths in the US, one of the most common cancers in the world. And I've been involved in writing NCCN guidelines for many years, more than 5 years, more like 10 or 15 years. Anyway, you all are familiar with the fact that low-risk patients and some favorable intermediate-risk patients may be considered for active surveillance or treatment. But certainly when they get to be unfavorable intermediate risk and high risk, the treatment options include radiotherapy plus or minus hormone therapy, and these are consistent and detailed in the NCCN guidelines. I think one of the things to keep in mind is that the high risk and the very high risk patients are essentially the same, with the only consideration of whether you would want to add another drug like abiraterone. But it's also important to know that there's an implication by the fact that the sequence is radiation and hormone therapy ahead of radical prostatectomy. because we think the data is better for radiation in high-risk patients. With the new NCCN guidelines, we've updated to moderate hypofractionation. You'll see some of the schedules for moderate hypofractionation listed. You can find them there. I rarely use these because if I'm going to treat only the prostate, I tend to use ultra hypofractionation or stereotactic body radiotherapy. My most common is to use is 950 times 4, although for patients that are older, that have bigger prostates, the morbidity is slightly lower with 725 times 5, but all of these are considered acceptable. And then we also had this added recently, the use of SBRT as a boost instead of using brachytherapy. So for those of you that need to go to a reference to look at what is acceptable in terms of fractionation by NCCN guidelines, these are summarized in the NCCN guidelines. I'm sure you can get that online. This is a recent paper that we published called Delayed Definitive Management of Prostate Cancer. What do we know? Excuse me. Frequently, I tell my patients, we're not interested in the fastest treatment. We're interested in the best treatment. And it's better to take your time to get the right treatment than it is to get the fast treatment. And this interest in the impact of delay was started out because of COVID, but also related to other data. So what we did, and I don't have time to dig deep on this, is that we pulled together all the studies we could find that were based on randomized trials where people got either immediate radiation or delayed radiation or immediate surgery or delayed surgery. And then we took a whole bunch of post hoc studies all together. And the bottom line is that for patients with low risk or very low risk disease, delays up to 7 years may be safe for patients that have low risk disease, but favorable for intermediate risk, 6 months or more is probably safe. And if you add neoadjuvant hormone therapy, it's probably even safer than that. And the same thing with people that undergo radical prostatectomy. The hormone therapy does not improve the results, but you can delay treatment. So it's important for you to have a conversation with patients to first relieve them of anxiety about delays and then explain to them that it's been well studied and it's safe to take your time and get the right treatment. Now, one of the problems is that the urologists have been taught that that surgery is better than radiation. And part of this is due to a bunch of biased literature. For example, there's something called attribution bias. The way that death certificates are set up, especially in the US, is that if a diagnosis is listed anywhere on the first 3 lines of a death certificate, it can be attributed as a potential cause of that person's death. And because patients that undergo surgery have less comorbidity, they're less likely to die, and therefore they're less likely to have their death attributed to prostate cancer. There are also differences in patient selection. There are fewer trials with surgery. And in the retrospective studies, many of them have missing data like PSAs, percent positive biopsies, and they tend to select very large population-based groups. So they'll look at 30,000 patients, and they'll be able to get a p-value that's statistically significant, but clinically not important. And they use it to argue for surgery. And I'm going to talk about some of the data on hormones and radiation. The other thing about surgery that is it has a higher 30, 60, 90-day mortality rate. It has a higher risk of erectile dysfunction and incontinence. And although there's an increased risk of second cancers with radiation, most of the studies are flawed in terms of how they estimate the risk of second cancers because they use surgically treated patients as a control group. And I'll talk about that in a second. So this is one of those classic papers, and when it was first published, all the urologists were saying, oh, this systematic review and meta-analysis proves that surgery is better. It's flawed in many ways. I've written letters to the editor. There are other studies. This is one of those large studies. They analyzed patients and they tried to adjust for things they could adjust for. And they said that the survival rate was better with surgery. Now, here they have 13,985 patients, and the percent difference at 10 years is tiny, and they can't really correct for all those. And so you get statistically significant differences, but this ignores all the potential biases. So these are some of the data that are classic data explaining how the biases are seen. The study on the left is from a study where they adjusted for all the comorbidities they could think of. What you see here is that the black line is radical prostatectomy. The red line is people that didn't have cancer, and the radiation is the green line. What you can see is that people that underwent radical prostatectomy had a better survival from all causes than people that did not have cancer at all, suggesting just how highly selected these people are. This is another study, a separate study, looking at over 13,000 men who underwent radical prostatectomy. And they looked at causes of death. Their risk of heart disease, their standardized mortality rate, 0.27. Chronic respiratory disease, 0.12. Diabetes, car accidents. Radical prostatectomy cannot make you have a lower risk of infection, car accidents, or diabetes. But what this shows you is that the population of men who were chosen to undergo radical prostatectomy had a lower risk of all of these other things, and therefore they had a survival advantage. So if you look at all causes of death, they have half the risk of death, and they have half the risk of developing second malignancies. So when you go to analyze the risk of a second cancer, and virtually all of the studies do it using a surgical group as a control group, that analysis is fundamentally flawed. This shows the cancers that you see in patients that did not have the reduction in cancer associated with radical prostatectomy, lung cancer. That's just patient selection. All these things are just patient selection. So as a result of that kind of population-based data, so-called systematic review and meta-analysis, what we saw, this is published a few years ago, a rise in the use and the popularity of radical prostatectomy in patients that were clinically staged as T3. The surgeons convinced themselves that surgery was better and therefore justified in the higher risk patients. Now, what they don't have and what we do have, these are two different studies looking at the use of hormone therapy alone or hormone therapy plus radiation with high-risk locally advanced disease, and shows that radiation can make people live longer compared to just hormone therapy. The surgeons don't have that kind of data for patients with advanced disease. So this is one of my questions. Regarding hormone therapy with radiation in randomized controlled trials, which of these statements is true? Short-term hormone therapy is associated with an increased risk of fatal MIs. Data supporting dose escalation is more definitive than data supporting hormone therapy in intermediate and high-risk disease. The standard of care for patients with intermediate disease is greater than or equal to 6 months. All of the above are true, or none of the above is true. So are we taking a poll now?
Yes, we're taking the poll.
Okay.
So currently around 50% answered. So we are waiting for around 80% of people answering, and then I will end the poll. And then, do you see the poll window?
I saw it. I just closed it.
Got
Oh
it.
no, I closed the, yeah, I saw the window. I closed it. It didn't
Got
show
it.
the numbers though.
Yeah. So I'll let you know.
Okay. This is a tough question, actually, a little bit. One part's a little tricky.
Okay, so we have 85% answering. I'm ending the poll and sharing results. So most people answered all of the above are true. So 48% answered that.
Okay.
And then we have the third answer, 25%, second answer, 21%, first answer, 7%.
I love this. I love this. You know why? Because all of the above are false. None of the above are true. Despite the fact that there are people that have published studies that suggest that hormone therapy might increase the risk, the fact is that a systematic review and meta-analysis of all the randomized trials did not confirm that short-term hormone therapy increased the risk of fatal MIs. In fact, we did an updated analysis looking at long-term versus short-term. We still didn't see it. The studies that suggest there's an increased risk of MI are population-based studies, not the data from randomized trial. One randomized trial, which was the Spanish study, did suggest there might be a risk, but the risk was negative in all the other studies. Data supporting dose escalation is more definitive. Not true. There are no randomized trials that have ever shown that dose escalation makes people live longer, but there are numerous randomized trials that suggest that adding hormone therapy to patients with intermediate risk or high risk disease live longer. So hormone therapy is more proven. And this is the one that's probably most confusing. The standard of care with patients with intermediate risk is greater than or equal to 6 months. You could say 4 to 6 months, but not really greater than 6 months. In that we did a randomized trial called RTOG 9910. We randomized patients between 4 months of hormone therapy and 9 months of hormone therapy, saw no difference in survival. That is identical to the Irish trial by Armstrong that compared 4 months versus 8 months, and the Canadian study by Juanita Crook that compared 3 months versus 8 months. So for patients with intermediate risk disease, the best duration of hormone therapy and what should be the gold standard is 4 months of hormone therapy. So it's beautiful. Everybody got the answer wrong. Anyway,
Amazing, amazing.
yeah. So after I saw that paper by the gentleman that did the systematic review and meta-analysis that said surgery was better, I published this paper I'm going to talk about now. And before I did it, I created something called a reliability score. Like the highest level evidence is from randomized trials, so you get more points from that. If you used hormone therapy appropriately, short-term for intermediate risk, long-term for high risk, you got points. Did you adjust for comorbidity? Did you adjust for other predictors? Was your study 30,000, which is, I think, too big to get clinically meaningful, or tiny? You get less points. Did you adjust in your survival curves? And did you have all the data on Gleason scores, PSA, and T-stage? Some of the studies did not. So this is based on the hormone therapy was based on NCCN guidelines. So when I did an analysis of the literature of surgery versus radiation, what I found was that I identified 14 studies that had, actually, there were 14 altogether. One did not have cause-specific survival. So for this analysis, we wanted to focus on cause-specific survival. And we divided it up by a reliability score. So those studies that had missing information, that had a low reliability score, there was a difference between surgery and radiation. But if you had all the information, if you treated the patients appropriately, there was no difference. It was less than 1% difference in 10-year cause-specific survival. So this is analysis of the data, same kinds of data that they used in that meta-analysis. But in addition to that, we had this randomized trial that was published around the same time from Sweden. This is a small study showing prostate cancer-specific survival with surgery versus radiation at 10 years, no difference. And then, of course, we have the PROTECT study now, which is observation versus surgery versus radiation. And they both, surgery and radiation, both reduce the risk of metastatic disease compared to observation, but there was no advantage of surgery over radiation. And this shows the results of surgery versus radiation. So there's absolutely no evidence that surgery is more effective than radiation. But from the same study, we know that radiation has a lower risk of erectile dysfunction and a lower risk of incontinence. So this is the erectile dysfunction, sexual bother, incontinence over here, all of which are worse with surgery. And we know that we believe that some of the erectile dysfunction issues are related to dose to penile structures. Now, the bulb of the penis is actually not part of the erectile mechanism. So when we talk about bulb dose, what we really mean is dose to an area down here where the blood supply and the nerves are supplying the corpus cavernosus. So it's not that the bulb itself is part of the erectile mechanism. And when you design the radiation field and we use fiducial markers or some type of image guidance approach, you want to make sure that you don't unnecessarily irradiate the penis and penile structures. Now, this is from an old paper that we wrote where we pulled a bunch of studies suggesting there was a dose response curve. There were some other people that published studies where they said they did not see a relationship between penile bulb area and the risk of erectile dysfunction. And so in evaluating that literature, I created another reliability score. What percentage of the patients were potent before they had their treatment? If you start off with a study where half the people are impotent, then you're not going to see the dose response. What kind of instrument did you use? A shim, an epic, a validated endpoint? What was the doses to the PTV? How are they prescribed? If you don't give enough dose, you're not going to see it. If you give too much dose, you're not going to see a dose response. Did they look for a threshold dose? In our study, our threshold dose was over 52 gray. And how many people were defining the anatomy? It turns out there's significant inter-observer variability. And in our studies, we had a single observer, independent of knowledge of how the patients had come out. And so if you had all of these things, if you had potent patients, used the right instrument, had a dose response, you looked for a threshold dose and did the anatomy systematically, they had a high reliability score. All of those were positive for showing a dose response. But if you were missing some of these things, you were more likely to have a negative study. This is the study that talks about the 30, 60, 90-day mortality rate. So we know that surgery is, if you're more likely to die at 30, 60, and 90 days with surgery, that it's a bad thing, especially for elderly patients. So the surgeons are convinced that it's better, and I've already talked about this, attribution bias, patient selection, these statistically flawed things, and some of these other clinical endpoints. So really, I rarely recommend surgery for any patient, except under extenuating circumstances, like patient with a history of inflammatory bowel disease, patient that's had prior radiation is not a good candidate for salvage radiation, patients like that. Now, this is from a book chapter that we published some years ago, and this shows this is how our treatment sort of evolved early on with image-guided radiation, looking at how do you decide. We did a lot of brachytherapy in terms of, I used to do a lot of LDR brachytherapy. I've done more than 1,500 cases. We do a lot of HDR brachytherapy. We still do a lot of HDR brachytherapy. I stopped doing brachytherapy, and now most of my patients, if they're intermediate risk, I do SBRT, either monotherapy for the lower risk group or add hormone therapy short term for the unfavorable intermediate risk patients, and use it as a boost for high risk patients. When you generate a plan, when you do a computerized plan for a patient, what you're doing is you're promising the patient that what you see on the paper is going to, is that somebody at the door? Deborah, can you check the door? What you are going to accomplish is what you put on paper. And that means that you're taking into some assumptions about motion and margins have been adjusted for, and you're telling the patient this is going to happen each and every day, and all of these have to be based on evidence, evidence-based, and be logical. Now, this is from a paper that I wrote many years ago, over 30 years ago, basically making the argument that when we're treating prostate cancer patients, we don't need to be limited by using uniform margins all the way around the target, when the risk of complications is more related to the rectum. So I encouraged back then in defining the ideal margins to simulate the patients with the rectum empty and the bladder full, because then the prostate will be in the most posterior position. And then over time, this is prior to the use of fiducial markers. It turned out that years later, the people from MD Anderson did a study where they showed that if the patient was simulated with a full rectum, that those people with a distended rectum had a higher recurrence rate, because presumably as their rectum became empty, the prostate would move posterior and be underdosed. And also they had a lower complication rate. So this suggested that the rectum was underdosed. And this is why you need to do both image guidance and make sure that when the patient's being simulated, ideally the rectum should be empty. This is one of the first papers that we wrote using fiducial markers. Now we're going back 20 years. These are patients that had morbid obesity. So there were 3 patients that had morbid obesity, and we did put implanted markers in them. And we showed that if you didn't use implanted markers in some patients, like in this first patient here, this first image, you could completely miss the prostate, because the tattoos can be moved in obese people wherever you want. And if you lined it up based on those tattoos, you could miss the prostate. And so this paper was accepted by the Red Journal with no revisions, no corrections, straight up as a paper, just based on 3 patients. And so obese patients are particularly critical, but it's useful in all patients, particularly those undergoing SBRT. This is a digitally reconstructed radiograph from back in 2001, showing how we would use these images. We do digital reconstruction of the seeds, and then we would design treatments. This is a 6-field technique. So even those of you that don't have IMRT, if you want to improve the accuracy of your treatment, you can use a 7-field 3D technique, which is going to be more accurate if you use fiducial marker directed image guidance. This was a study that was done in Michigan, where people were looking at, well, maybe you just need to check the patient once a week and just make the adjustment and assume that you're going to capture it. And this shows how the errors are much tighter when you do daily imaging with gold marker seeds to make sure targeting is done. So these are some questions. Which of the following statements is true concerning prostate SBRT? The use of fiducial markers has been shown to improve the accuracy. Rectal distension at the time of simulation has been shown to be associated with a higher risk of PSA failure. Obese patients are most likely to benefit from IGRT, and IGRT has been well studied in post-prostatectomy patients. Number 5 is all above are true. Let me know when you, I guess I'll wait for the.
Yeah, sounds good.
Okay.
I'll let you know. I think this time everybody should be correct.
I think so. I think it's,
There was one comment in the chat that only a true master can figure out a question that everybody would get wrong. So
what
that's a
about a
compliment
question
for
that, what
you.
about a question that everybody gets right? I
Yeah.
think. Let's see. Most people will get this one right.
Yeah, I think most people would. Okay, so ending the poll, so 88% answered and sharing the results. So
Wow.
most people answered 5. All of the
Yes.
above are true. But still there are 40% that answered the first one. The use of fiducial
Yeah.
markers have been
So I
shown
showed
to.
the data from MD Anderson that showed how distended rectum increased the risk of biochemical failure and reduced the risk of complications. That's this study here.
Mhm,
There were more biochemical failures if the rectum was distended. So that's
mhm,
why that's true. And once that one's true, um, so that, and then obese, that was the other study that I showed.
right.
That was this study here that showed that in patients that were morbidly obese, if we didn't use the gold marker seed, in some of the patients, we would completely miss the prostate. So they're particularly likely to benefit. And this other study here was actually, maybe I didn't show that study, but anyway, it's been used
Mhm,
in post-op patients as well.
mhm,
So the right answer is number 4. Now, there have been a lot of studies published looking at hypofractionation, and this is one of the systematic reviews and meta-analyses, and basically concluded that the evidence suggests that it's an appropriate thing to use. That there's little difference in survival, METs or whatever, and it's very well generally well tolerated. So that's what their meta-analysis suggested. But the hypofractionation regimens and the SBRT regimens are partly based on this BED assumption that the alpha beta ratio for prostate's like 1.5 or 2, which is reasonable. However, this is an equation I created to emphasize the fact that in addition to a BED related to alpha beta, there's some other variables that are not considered in this equation. For example, when we talk about dosimetry, we typically are talking about small differences, 3%, 5%, but the alpha beta ratios of 1.5 or 3 versus 10, you're talking about a magnitude of 2. And, so the question is, how accurate can it be? And what are these data based on? These data are based on biochemical failure rates. And the problem is that biochemical failure has not been proven to be a surrogate for death. So basically, biochemical failure may not translate into improved survival. We know that the large fractions work, but that's just an empirical observation. And also the alpha beta ratio, this BED calculation doesn't take into account what, meaning what you radiate, where, and why, and how much you give. So caution, when we talk about this alpha beta ratio, it doesn't take it into account. Gleason score was the most important predictor of death. It doesn't take into account T-stage. It doesn't take into account age. We have a paper that we recently published in the Red Journal that shows that patients 70 plus or minus 5 years do better from a cancer outcome than patients under the age of 70. So that's not accounted for in any of these BED calculations. And so we have data that supports the fact that higher size fractions work, but it's not very granular, and we don't really know how all the other variables fit in there. So part of another aspect of the so-called faulty logic is target volume issues, radiation volumes, pelvis versus prostate, extended disease, and should we base it on PSA, and then the biomarkers we may talk about later. So here's an example of what I mean by how different endpoints can get you different results. So on the left is a nomogram that predicts biochemical failure in men who undergo radiation. And on the right is also a Catan nomogram that predicts the likelihood of metastatic disease. And the likelihood of metastatic disease is a more important predictor of death than biochemical failure. So if you look at the points at the top, you get 60 points for a PSA of 4. You get 30 points for T3C. So in this case, the PSA is more important relative to the stage and the Gleason score because PSA can predict biochemical failure better than other endpoints. But if you look at the risk of metastatic disease, PSA becomes less important than T-stage, seminal vesicle involvement, and Gleason score become more important than PSA. And since these nomograms, or since the alpha beta ratio data is based on biochemical failure, it may not be, there may be problems with it that we have to be aware of in terms of how we use it. This is the study that I first showed that age. So this is looking at biochemical failure stratified by pretreatment PSA. Excuse me, by pretreatment testosterone. So the testosterone did not matter, but you can see that the hazard ratio for biochemical failure with people greater than or equal to age 70 is 0.69. So age is a favorable prognostic factor in patients treated with radiation, but it's not a favorable prognostic factor in people treated with surgery. You can see the impact of Gleason score, and you can see the impact of PSA. But how do you build that into this BED model? It's not in there. And then we have multiple randomized trials that show that hypofractionation works. CHIP trial, people would compare conventional fractionation versus hypofractionation versus a lower dose hypofractionation. I think the scary thing about this trial, though, is that it seems like a single fraction would make the difference here because you have 19 fractions versus 20 fractions. And so there's a thin line between what's enough and what's not enough. You can read the paper for the margins that they describe, but at the end of the day, you can see that the best control rate was in the 60 hypofractionation was slightly better, but the worst one was the 57. So one radiation treatment made a difference. And so it makes us a little nervous about assuming that we know all the details of how this should be done. But at the end of the day, the bowel problems and the bladder problems and sexual functions appear to be reasonable. So this would save a lot of money and a lot of work, and really has redefined what the standard should be. We have similar data from the RTOG. This is an RTOG trial we call 0415, but for low-risk patients. And they were randomized to 73.8 gray with conventional fractionation over 8.5 weeks, 41 treatments, versus 70 gray and 28 treatments. No hormone therapy. And if you look at long follow-up, there were more biochemical failures in the higher doses given with a longer fractionation than with the SBRT. With the hypofractionation. And this observation would support the notion that there's a higher BED with the hypofractionation, consistent with the notion that the alpha beta ratio is very low with prostate. I'm going to shift now and talk about the issue of post-op radiation. One of the early studies in post-op radiation were the SWOG, the EORTC, and a German study from Berlin. And those studies all suggested that biochemical failure was improved with post-op radiation. But they didn't use early salvage as defined in the protocol. And so 3 additional studies were performed. Radicals, Rays, and GITIC-17 were performed, and they attempted to answer the question about whether you should just give adjuvant radiation or whether you should wait for early biochemical failure and then do the treatment. And to make a long story short, they concluded that it was better to wait. But my conclusions are that in patients that are extremely favorable, if you look at their eligibility, patients were eligible for randomization simply because they had a PSA greater than 10 or a Gleason 7 or positive margins in a PSA less than 0.1. I never offer adjuvant radiation to somebody simply because their pre-op PSA was greater than 10 or their Gleason was 7. And if you look at the cohorts in this study, 80% of them did not have seminal vesicles involvement, and 85% of them had a Gleason score of less than or equal to 8. So they had very few high-risk patients. They had essentially no node-positive patients in 2 of the studies. And so they don't really answer the question of whether adjuvant is appropriate in high-risk patients. They answer the question about adjuvant in favorable patients. Now, when we treat a post-op patient, part of the question is, what should we radiate? And this is from a classic paper that was done at UCSF. They had 114 patients that had a rising PSA after surgery. And Dr. Shinohara biopsied all of them. And he found that 54% had a positive biopsy locally. 2/3 of those were at the anastomosis in the bladder neck, and 13% were in the trigone. So when we treat post-op patients, we routinely have fiducial markers. There are 2 seeds that are placed here at the bed. This is from that patient that I treated who had a nodule, a biopsy-proven nodule. I have the urologist place 2 gold marker seeds. This is a contrast in his urethra. And I treated him. And after his first treatment, the image on the right is a digitally reconstructed radiograph, and you don't see the seeds in there. So the therapist had given him a couple of treatments and said, you know, Dr. Roach, that patient that you put those seeds in, we don't see them on the image. And I said, well, move it back 5 millimeters. So if you look carefully on the right, they moved it back, and there are the seeds. So for his last 2 treatments, I put on a postage-sized field to boost this, and it looks like he got over 80 gray. His PSA was 0.4 when I treated him, and it became undetectable and remained undetectable. So it's very important to be able to know where your target is in order for you to treat it appropriately. This is from a study that we did looking at post-op patients. And we looked at what kind of error we would have had if we had not used the fiducials, if we just used tattoos. And we would have been off by more than 5 millimeters, almost 40% of the time inferior superior, about 28% of the time ante post, and right to left about 14. If you add all this up, close to 50% of the time we would have been off by 5 millimeters, which means that we may be underdosing the anastomosis and overdosing the rectum or the penis or the bladder neck. Now, when you treat patients in the salvage setting after they've had through a radical prostatectomy, this is a randomized trial called the SPORT trial, where they were randomized to only have prostate bed-only radiation, which is shown in red, prostate bed plus short-term hormone therapy 4 to 6 months, or prostate bed plus pelvic nodal radiation. And this is showing that with reasonably good follow-up in a big study, that adding hormone therapy and pelvic nodal radiation in high-risk patients undergoing salvage radiation, that was beneficial. Now, in those patients who are not being treated with whole pelvic radiation, this is looking at a true pelvis type treatment, a randomized trial comparing 62.5 and 25 versus 66.6 and 37, showing similar outcomes with hypofractionation. So in the post-op setting where patients are relatively low risk and you're only worried about treating the bed, you could consider such a fractionation. But typically when I'm treating a patient who's undergoing salvage radiation for high-risk disease, I'm adding hormones and I'm treating the nodes. Now we have a whole flurry of different kinds of technologies that could be used. I use the CyberKnife to do SBRT for prostate mostly, although we can do it with a LINAC when patient's not suitable for CyberKnife for some reason. Excuse me, we also do tomotherapy for pelvic nodes. We do intraop radiation. We do HDR brachy. We don't do LDR. So the question is, which one of these should we use? And what about others? Well, I think the SBRT is analogous to HDR brachytherapy. It's less invasive, doesn't require anesthesia, lower risk of bleeding and infection, doesn't require pain medication, and is very effective, and you can use it as a boost in a variety of patients. This is a comparison looking at the rectal dose, comparing CyberKnife with HDR, and the dose volume relationships are very similar. So we think we can recreate dose distributions like HDR. This is from a book chapter I wrote where this shows, this is a CT scan. We have a urologist place a gold seed at the base, one at the midgland, one at the apex. We then do CT MR fusion to make sure that we have the anatomy accurately defined, particularly the urethra. And then we use hundreds of beams coming from all different directions, and we cut out a place where we spare the urethra in the prostate area to prevent a hot spot from occurring there. And the dose constraints that we use are identical basically to the dose constraints we use with HDR as a boost and as HDR monotherapy. And basically the simplest one is we try to keep the dose to the urethra less than 120% of the prescription dose. This is an example of a patient that I treated, 63-year-old with unfavorable intermediate risk, 5 or 10 cores. This is a CT, and you can see his gold seed at the apex. You can see one at the midgland or base. This is a coronal axial image. And then this is an MR image. This is what we call a vibe image or a Dixon image, where on this T1 image, you can see the seeds better. And we've now superimposed these markers for our planning purposes. And now this is the T2 image that we use to better define the anatomy for the prostate. And then we generate a plan like this. In this case, this patient's going to get SBRT with a boost to the pelvic nodes and short-term hormone therapy. When you're simulating these patients, you have to take into account things like at the time of simulation, the rectum might be distended. So you have to have what's called, you have to get a tube, a red tube. We use something to deflate the gas. It's a good thing for residents. You got to show them one time. You put a lot of lube on it, and while the patient's on the table, you shove the catheter up into the rectum, and it lets the gas out. And then you can do the simulation with the rectum empty, and you can use the gold seeds to guide the treatment. The other thing that you worry about sometimes is people with large median lobes. Generally, the median lobe that bulges into the bladder is not involved by cancer. So unless you have a patient who has like diffuse involvement, like 15 out of 15 cores positive, especially if their disease is like mostly at the apex or midgland, then we assume that the median lobe is largely not involved, because if you treat the median lobe to a full dose, you're going to treat a lot of bladder neck and cause a lot of morbidity. You can, sometimes people do something called a TUIP, transurethral incision of the prostate. They actually go in to remove the median lobe. Most urologists that I work with don't really want to do that. TURPs are dangerous. That increases the risk that the patient's going to develop incontinence afterwards. So you don't want your urologist doing TURPs on your patients before you radiate them. It can cause something called suburethral necrosis, where the urethra calcifies and the patient becomes incontinent. You can give them neoadjuvant hormone for 2 to 6 months and shrink the prostate. That will help shrink the median lobe. Or you can decide arbitrarily, especially if you look at the MR and the median lobe looks like it's full of BPH nodules, which don't look like cancer. You can underdose the median lobe specifically in order to keep the dose down to the bladder neck, or just exclude it completely if you think the patient's not at risk for involvement of the median lobe. This is a patient, you also don't want to chase the tips of the seminal vesicles. Usually when the cancer invades the seminal vesicles, it's within the first centimeter that the seminal vesicles are involved. Excuse me. And if your biopsies only shows disease in one gland, one side, like right side or left side, and what just at the base and nothing in the left side, sometimes I'll just treat one seminal vesicle because it substantially increases the dose to the rectum. When you look at the literature on SBRT, beginning about 10 years ago, people started doing cost effectiveness studies in the US, suggesting it was substantially cheaper, certainly a lot fewer treatments, and therefore it could be cheaper not only for the delivery, but also for the patient in terms of coming in. But they suggested that the toxicity might be slightly worse when you compared it to conventional radiation. But this involved people early in the learning curve of doing SBRT. There are other population-based studies that report excellent biochemical controls and excellent overall results. This is the systematic review and another systematic review and meta-analysis that suggests it's highly effective treatment. This is from another systematic review and meta-analysis that shows 10-year control rates close to 90%. Excuse me. And if you look at patient-validated quality of life endpoints, you look at urinary bother, bowel bother, and sexual function, the results are quite good. If you look at the morbidity is relatively low and the control rates are relatively high in terms of the groups that have been studied. If you take patients with unfavorable intermediate risk disease, this is from several studies that are treated with SBRT. Without hormone therapy, the 5-year control rate is approximately 75 to 80%. I think it's better if you add hormone therapy plus or minus the pelvic nodes. Here's an example of a patient who's getting, he has a gold seed here that we set him up to. This shows the dose distribution on the prostate and the pelvic nodes, including, we go up to L4, L5, and include the presacral nodes, the internal and external iliac nodes as well. This shows the internal, external iliac nodes as well. This next. And this is from a propensity matched comparison that we did at UCSF. We took patients that got external beam plus hormone therapy plus HDR brachytherapy and compared it to those people matched who got SBRT as a boost instead. And both of these results at 10 years was about 85%, and they were very similar. So we think that SBRT can be used if done properly in lieu of HDR brachytherapy, but we continue to do both. When you're covering the pelvic lymph nodes, this is a good resource. This is a review article from over 20 years ago defining these various nodal sites. Because you want to make sure that you include the nodes that are there, especially internal obturator, external iliac, and the presacral nodes. But sometimes you need to get periprostatic nodes as well, including when a patient has extensive involvement of the apex of the prostate, you can get perirectal nodes that may be at risk for involvement as well. This is from a review article looking at a template where they did imaging intraoperatively. They injected the patient, and then they used a sort of a Geiger counter type thing to find the nodes. And you can see that the nodes are widely distributed. So treating the true pelvis with radiotherapy is not going to cover very many nodes. That's why for RTOG 0924, our superior border was put at L4, L5, included all of these nodal areas. So we have these major randomized trials that did SBRT 36.25. This is the most common in the US, 5 fractions we did versus 12 fractions in RTOG 0938. This is a phase 2 study. These are phase 3 studies, 7 fractions versus 39 fractions, 36.5, 5 fractions versus radical. This is a PACE A. This is a quality of life endpoint that shows better quality of life with SBRT. And PACE B, again, 36.25 versus 78 with conventional fractionation. All of these studies support SBRT, and this fractionation was as good as 78 gray, gives better quality of life, and is certainly cost effective. What about the use of MR-guided SBRT? This is from a randomized trial that was reported last year in JAMA, and they concluded that they did a MR-guided treatment And the primary endpoint was physician score and genital urinary toxicity. And they used NTC 4.03 scale, and they reported their results. Now, the problem with their results is that what they did is they compared patients who were treated with what they call CT guided with a bigger margin than those with MR guided. So for the MR guided, they use 2 mm margins. And what I've done here, suppose you did a study of MR guided with 2 mm margins versus MR guided with 4 mm margins. This volume is much bigger. And so if you had more complications with this one, you can't decide that this MR machine is better than this other MR machine, just like you can't decide that CT guided is inferior to MR guided because the CT guided had bigger margins. And in fact, it wasn't CT guided, it was guided by the use of fiducial markers. So here's another set of questions. Which of the following statements is not true concerning SBRT? A single randomized trial using MR-guided proved toxicity was reduced compared to CT-guided. Retrospective studies have shown that SBRT as a boost appears to be comparable to HDR for high-risk patients. At least 2 systematic reviews and meta-analyses have been completed and are supportive of SBRT, and several phase 2-3 trials have been completed and suggest SBRT is very safe, which is not true. How we're doing?
60% answered, so waiting for 85%. You might have tricked them.
No, I mean,
No.
it's a challenging question, but
Right. Not true. So it's a not true question. So
yeah,
90% answered and sharing the results. So most people answered, it's split between option 2 and option 4,
okay. So the correct
33%.
answer is 1.
Mhm.
MR guided the study. The authors concluded that MR was better, but in fact, because they used different margins for the MRI and CT, what they proved was that bigger margins were associated with more toxicity. It didn't prove the MR was better. And I showed multiple retrospective studies and multiple studies, systematic reviews that we went through that all suggested that SBRT was reasonable.
Mhm.
And we have several phase 2-3 trials. So the not true is the MR Linac is proven to be superior to CT guided. In fact, the CT guided was not even CT guided. It was guided, both arms used a 3 Tesla MRI to define the prostate anatomy. And then the CT, so-called CT guided, used fiducial markers to line the patient up, but they arbitrarily chose to use bigger margins. The MR guided cost a lot more money and took a lot more time. It took 5 times as long to deliver the treatment. So it was at risk for more problems with accurately targeted. It was supposed to be adaptive radiotherapy. So in my opinion, they did not prove that MR guided was better. So these are major take-home messages. Definitive radiotherapy, when well administered, appears to be at least as effective as radical prostatectomy. I think it's better in high-risk patients, especially patients greater than or equal to in 70 plus or minus 5 years. And this better for radiotherapy is in part because of better quality of life and outcomes from phase 3 trials. The optimum duration of hormone therapy continues to be effective in prolonging survival in intermediate and high-risk disease. And there are some biomarkers that give us insights, but dose has not been shown in prolonged survival. And new technologies such as MR-guided treatments need to be studied better with less bias. both hypofractionation, ultra hypofractionation should be considered as critical to do it properly. You need to understand patient selection, understand the anatomy, use optimum image guidance technologies, and optimum dose constraints. And that ends my presentation.
Thank you so much. That was an excellent and very insightful talk. We will now proceed with Dr. Bordiuh's presentation and questions, and we'll keep the questions to you, Dr. Roach, to the end.
Okay.
Thank you.
Thank you. I'm trying to share my screen now. Do you see my screen?
Yeah, we see. Do you mind putting presentation? Perfect. Excellent.
Yeah, thank you. My name is Bordiuh. I'm radiation oncologist in Pro Clinical Oncology Center, and today I want to show you some clinical cases from our clinic. First of all, I want to say a word of thanks. It's a great honor to be a speaker on such conferences in this call. And it's a big honor to speak with Mark Roach about prostate cancer, because we use formula Roach every day in our treatment. So it's very interesting to discuss and to hear your opinion about this. First case, it's prostate cancer. Patient 65 years old, PSA more than 200. We have adenocarcinoma of prostate, Gleason 8. Bone scan, CT, everything okay, and the patient refused surgical treatment after he go to the MDC, and we decided to use androgen deprivation therapy and after external beam radiation therapy. We used to calculate formula Roach, and as you see on my scan, it's very high risk to invasion to have positive lymph nodes. So we decided to radiate pelvic nodes as well. So we decided to use 2.5 gray for the prostate with seminal vesicles and 1.8 grays in 28 fraction. We received a pretty good result, but in 2 years we had post-radiation proctitis, which we saw on MRI and colonoscopy, and we had a biopsy. And after that, patient received treatment of radiation proctitis, and now everything okay in this patient. So my questions for this case: do you agree with the patient treatment plan? Should I read all questions or one by one?
You're asking the group.
We are asking, so she's asking you. So if you don't mind reading the questions and answering, that would be great. Thank you.
Yeah, so the treatment plan was reasonable. I don't know, I didn't look at the margins. Usually patients don't get ulcers with radiation. It's uncommon. But
they are near 1 centimeters.
Yeah, but usually my posterior margin is tighter than 1 centimeter posteriorly, especially if we use image guidance. So this is one where his rectal dose must be high. And in fact, if you look at the sagittal image, the lower image on the right, you can see that green area there.
Mm-hmm.
The green area up by his seminal vesicles. That's probably a hot spot. And it's in his seminal vesicles on the axial slice as well. So both of those hot spots were near his rectum. We don't usually treat the seminal vesicles to full dose. We usually treat, unless we know a seminal vesicle is involved, we don't treat them. And when I use the Roach formula, by the way, I don't go above 100. I just say the risk of lymph node involvement is 100%, seminal vesicles 100%, and extracapsular extension is 100%. Clinically, I don't have a 400% probability. So it's a minor detail that, you wouldn't know, but we don't usually go above 100. That's just say it's involved, so, and the reason that could be important is if you ever do a population-based study when you're trying to estimate what the risk is in a group. You can't use their average risk, because if you go above 100, you go to 400, that's going to make 4 people have 100%. So you want to do it by patient, and you want to cap it at 100% if you think it's really involved. By the
But
way,
help us.
there's one more thing one more point I would make, and that is that it turns out that PSA is overrated as a prognostic factor. We wrote a paper years ago. I was going to try to pull it up, but I don't know if I can find it. We did a study of patients that had PSAs over 50. And it turned out that PSA isn't that important. The Gleason score is actually far more important than the PSA over 200. So you can have actually there's a case series in the surgical literature where they had patients that had PSAs of 200 who had radical prostatectomies who actually had organ-confined disease. So what happens is if the cancer, if you have the median lobe involved, they can have a very high PSA because sort of obstructive process. So the PSA itself isn't, but otherwise, I think how long was he on hormone therapy?
He was on hormonal therapy near 2 years.
Okay. One thing when you interpret the PS, you could move to the next slide. When you show his PSA without that PSA, without his
Okay.
testosterone, we
Yes.
don't know how to interpret the PSA.
Yeah.
So if you take a patient who's 65 and you put him on, go to the next slide. Go to the next slide. So his PSA was 0.2, but we don't know what his testosterone is. And without a testosterone, we really don't know his disease status. He may look like he's doing well, but it can take a few years for testosterone to come back if he's been on therapy for 2 years. But the basic approach I agree with. Okay.
Our next question: what treatment options can you recommend for these patients with high or very high risk? Do you agree with pelvic node radiation, or what you can recommend?
Yeah, for a patient with a PSA that high and a Gleason that high, yes, I would give hormones and radiate the pelvis. In terms of the proctitis, some people will give steroid enemas. Hyperbaric oxygen works for radiation cystitis better than proctitis, but sometimes they go together, and I'll end up treating them with hyperbaric oxygen. I would not omit the nodes. The treatment, if I do SBRT treatment, it will be faster because I give 2 CyberKnife treatments followed by 25, so it'd be 27 sessions. I think you gave 28 sessions, so not much difference.
Yes, 28, yes.
Yeah, and in a case of recurrence after external beam and nodes, then I would do probably if the recurrence was in the field or adjacent to the field, I might treat with SBRT, assuming it's a regional or a marginal miss. If it's outside the field, then it depends on where it is, but I would consider doing SBRT, or if he recurs in his periortics, I might treat his whole periortic chain from above the L4, L5, or L5S1 all the way up to the diaphragm, if his disease appears to be controlled.
But if we have a recurrence in node in the field where it was external beam radiation therapy in pelvic node, so what do you recommend after radiation?
If they recur, you're saying
Yeah.
if they recur in the field, well,
Yeah.
you got to think about why did they recur in the field? Like if they recurred in the field because the dose was not, like if their node appeared, if they were node negative and you gave them a full dose and that node is close to bile, then you're somewhat hampered. Usually they won't have progression in the field. If it's at the edge of the field, then the problem is because of setup, day-to-day setup variation, target motion stuff, you may have underdosed that node, in which case, as long as it's not up against bile, you can do SBRT just to kind of berry pick that node. but you gotta have to do that carefully. But usually you don't see nodal failures in the field if it's gotten full dose and the nodes were not involved there. So if you do, especially if you do a PSMA PET, like if you didn't have a PET, you don't know if the nodes were involved, it's one thing.
And that's a problem in Ukraine. There are
Yeah.
only 3 PET CT scanners in Ukraine.
Yeah, well, if you
They
can
are
get,
all
if,
in Kyiv. Yeah.
yeah, well, it's good to have a PSMA PET, but if you don't, then usually the nodes that people progress in are nodes that were not adequately covered, not dead center in the middle of the pelvic field.
Dr. Roach, I want to go back to margins. I think margins is very important here because it looks like the proctitis was 2 centimeter wide. And I was wondering if you can comment on the margins you use together with IGRT technique you use at UCSF.
Well, if you see, whenever I radiate somebody, I've got 3 gold seeds. They're 1.1 by
Right.
3 millimeter, and they're in the prostate or in the anastomosis. So the therapist, so our treatment is accurate within a couple of millimeters. So
Right.
before every treatment, the patient is imaged and made sure that that thing is right on those gold seeds. Therefore, like for SBRT, I might use 2 millimeter margins. Sometimes I use no margin if there's a lot of rectum in the field, but I never use a centimeter anymore because I'm doing image guidance. And the thing about what you may have is a situation where the patient, I showed the example of patients who present when they're simulated with the rectum is empty. And then as they get treated, the rectum becomes, no, the rectum's full and the rectum becomes empty and they have a lower risk of rectal morbidity. But if that patient was simulated with the rectum empty, and then you put that margin there, and the patient doesn't have much movement, they will systematically get that margin every day. And that margin is bigger than the margin that you need, because usually when people recur, they recur in the site of where they had bulky disease. And rarely is that not something that you can adequately cover without, you can still use a tighter margin right at the rectum. That's the point I was making about using non-uniform margins. You put the margins bigger in places that there's no dose limiting structure lateral to the prostate or in front of the prostate that you're going to hurt. So you can put bigger margins everywhere around the prostate, except you don't want to put too big of a margin at the bladder neck, and you don't want to put too big of a margin at the rectal interface.
So
That's good. Thank you.
if we're talking about full rectum, so in this case, the patient received 28 fractions every day. So can we recommend to use enema or some other to make empty rectum, or what you can recommend about this? So it's pretty difficult to ask patient to use enema every day before treatment, 28 times.
Well, you do image guidance. If you don't have fiducial markers or you're using cone beam CT on the table, I mean, you need to, the prostate position is variable. And there's nothing you can do about your treatment. It's not going to be accurate unless you use some type of image guidance. I always prefer fiducial markers because the therapists have 3 points in space that they can accurately align to. If you use cone beam CT, it's still a fuzzy image that they have to adjust for. And it's not going to be quite as accurate as using fiducial markers. People used to use something called a BAT, which was an ultrasound device that was used. That's not so accurate either. And I also have concerns with that MRI study. They were using a 0.35 Tesla MRI. That's not a very sharp MRI, and they're using that as adaptive. And we don't know what the inter-observer variability is for that is either. So, I mean, you cannot beat the use of fiducial markers. And I think what you should do is train your urologist to give up radical prostatectomy and learn how to put in the gold marker seeds so you can improve the accuracy of your radiation.
That's a great quote. Thank you. Thank you for that. So let's move on to next case.
Right, right. Case 2, it's patient, 65-year-old 2. PSA at the start is 93. In this 2022 ADT started. And bone scan, it was everything okay. On CT, we received prostate cancer. There was MRI, pelvis MRI. So it was enlarged prostate in size. And the patient go to the oncologist and received the surgery treatments post-radical prostatectomy. By histology, it was adenocarcinoma of the prostate 10 Gleason. And you can see it is a describing of histology on the screen. It was lymphovascular invasion, it was perineural invasion, and patient wasn't at tumor board or MDC. In 1 year, PSA was pretty low, but in 1 year, in 2024, it was we received 0.2. So patient come to our clinic, and our MDC decided to make radiation therapy in such dose what you can see on our screen. We decided to use pelvic radiation too because risk of node invasion was more than 100%. And
Okay, before you leave, can you go back? I have a question. You say that the apex resection into the resection margin and seminal vesicles on the right behind the left. I don't know what you mean. Was it involving the right seminal vesicle, or was it
yes,
involving both seminal vesicles? Pardon me?
Yes, sorry.
Is it involving the right seminal vesicle or the left seminal vesicle or both seminal vesicles?
It was involved of both the seminal vesicles, and the right was more involved than the left.
Okay.
So here you can see our contours. We use everyday dose 2.3 for the prostate bed and bed of seminal vesicles, and 1.8 for the nodes, pelvic nodes, in 28 fractions. We received good results, and of course, I want to ask you, what do you think about this plan of treatment? Because it's not classic dose we use for the tumor bed, prostate bed. And what is your advice about period after surgery before adjuvant external beam radiation therapy? And in what cases you prefer to do adjuvant, and when you try to wait and use the salvage treatment?
So,
I'm sorry.
yeah. So for this patient, this is one reason why we like to use fiducial markers, because if the rectum is distended one day, is you're going to underdose it, or it, depends. Especially in a patient that has seminal vesicle involved, bilateral, you're going to get more rectum in the field because you're trying to cover the seminal vesicle. So you're going to get more seminal vesicle, more bladder in the field because you're trying to go up to the bed of where the seminal vesicles were. But I think you have to do something like this. But it's ideal to use image guidance with it to make sure that you're hitting the right spot. So I think it is appropriate to radiate the pelvic nodes in this setting, given his histology. If you look at the data from Johns Hopkins, if you look at patients that have seminal vesicle involvement, 50% of them have lymph node involvement. So he was at risk for lymph node involvement even at the time of the surgery. The other thing is you didn't talk about his lymph node dissection from his radical prostatectomy. But so he needs to have his lymph nodes treated. I think the doses that you've chosen are pretty reasonable. And I don't know about fusion for contouring in the adjuvant treatment, it's about his anatomy now, not what his anatomy was before. So you don't want to radiate, you want to radiate a volume that would take into account the prostate bed, but really his anastomosis is most critical because he had extracapsular extension at the anastomosis. So you want to make sure you hit that every day, and that's why you need some type of image guidance.
Yes, of course, we use it. And but is it necessary to make fusion, for example, CT before the surgery and CT scans?
No,
No.
no. I mean, first of all, before the surgery, the prostate was sitting in the middle and the bladder was on top of that. And now you've removed the prostate and now you've brought the bladder neck to the external sphincter to form the anastomosis. You don't want to radiate all that bladder neck because, you know, you may want to radiate around the bladder, but you don't want to go as high up as the prostate was. You do need to treat some of the bladder wall, but you don't want to radiate a large part of the bladder because then if the patient is incontinent, he won't be able to have a full bladder. He'll have an empty bladder. And when his bladder is empty and you radiate to cover where the prostate used to be, you'll radiate a large portion of his bladder, and then his bladder capacity will be reduced. Over time, his bladder will become shrunken and it won't be able to open up, so he won't have any bladder capacity. So you want to make sure you treat him with a bladder full, and you need to treat, the key part is the anastomosis and the seminal vesicle bed. So you do need to go sometime posteriorly, but you don't need to bring that dose all the way anterior and get a whole lot of the bladder neck.
So I want to go to the slide before. Do you agree with this contour? So we used to make contour like toilet shape. We have some literature about this. So
Well, I mean, one thing you know for sure, if you look at, for example, the axial slice, see that yellow circle in the middle? That's the bladder, right?
Yes, here is this bladder.
There is absolutely no cancer in the middle of that bladder.
So you recommend to use CTV like just on the wall of the
So
bladder?
I do a concavity inside the bladder
Mm-hmm.
because that's just urine. And you know, as you slide up and down that's that area, there's no, but what that does is, if this is how you did the plan, if you look at that sagittal image, you see how much bladder is outside the field. But after you start radiating the patient has frequency and they can't hold their bladder long, his bladder will shrink down and all that bladder could end up in the field. And you give that whole bladder the whole dose, and then the patient's bladder capacity will be reduced. So if you try to carve out some of the bladder, then you would reduce the chances as bladder capacity is reduced.
What do you think about the fall of this bladder? Is it normal for making radiation therapy, or we must to make a bladder more bigger in
Well,
adjuvant?
when a man's had a radical prostatectomy, sometimes they have a certain amount of incontinence and they can't hold a fuller bladder. So you can tell them to have a full bladder, but they may not be able to hold very much. So you want them to have as full a bladder as they can, but you can't always control that. Neither can they.
So our task, we should make our CTV lower, just input the wall of the bladder there.
Well, I mean, if you look at that sagittal image, the anastomosis is at the bottom of your field. And I told you that the study that Dr. Shinahar did all those biopsies for, the most common place for a recurrence is going to be at the anastomosis. But you're pretty tight on the anastomosis because you see the bladder neck is formed right here at the bottom, and you're pretty tight on the anastomosis. So if you have set up air and target motion, you could underdose the area where the recurrence is. Now, having a PSMA PET would help because that might show that that's where the disease is. And then above that, you've got that part of what you call the toilet bowl thing. A lot of that bowl is bladder with no cancer. There's no possibility that cancer cells are floating around in the middle of that urine. You're not going to cure cancer by radiating that much bladder. So it needs to be a little bit more concave down at the level of in the bladder area, and to make sure that you're getting the bladder neck better covered.
Yeah, thank you for this information because it's very important for us. Many doctors in Ukraine used to treat big part of the bladder, so it's very important. Thank you.
Mhm.
So, and the last question you answered us already, so we can reduce our volume and go out from the place where we have urine in the bladder, just inputting bladder wall in the field. Thank you. And our last patient is patient about SBRT, as we're doing here in the Oncology Center. There wasn't any complaints in this patient. It's pretty low PSA. MRI, CT we have. And we decided to use androgen deprivation therapy in the first step, and then external beam radiation therapy, and it's just SBRT. Here you can see our contours and the result of our plan. We use 6.1 in 7 fraction for prostate and 1 centimeter approximal part of seminal vesicles. So we had nice result in it. And I'm interested in your opinion about this treatment plan of patient. Maybe you decided to observe this patient, or what do you think about this?
No, I think I don't observe very many Gleason 7s that are young and healthy. I think they need to be treated. Active surveillance is good for 6s are very elderly people with 7s, but for a young man, I would treat them. I don't use this fractionation. I do 725 times 5 or 950 times 4, but the 7 fraction one is likely to be tolerated a little bit better, especially if you're not using fiducials and that sort of thing. There are studies suggesting that prolonging the separation between fractions seems to reduce the morbidity. So that could be a good option in your case. Could you go back one slide? And go back again. Oh, you gave hormone therapy.
Yes.
Which, well, when I do prostate only radiation, this is the
we don't we are radiation oncologists. We don't use an ADT in our treatment. We have oncologist who follow up this patient and who starts some treatment. That's why he decided to start from androgen deprivation therapy.
Okay.
And then,
But if you stop sharing for a second, let me share with you.
yes, of course.
Okay. So this is a study that we did, 94-13. We randomized for people to get hormone therapy before the radiation or after the radiation. And we randomized whole pelvis or prostate only. And one of the observations we made was this. There's a sequence-dependent interaction between the hormone therapy and radiation. So let's just focus on prostate only. That's the PORT here. If you look at the 10-year progression free, if you give with prostate only radiation, it's better to give adjuvant hormone therapy. So in this patient's case, if I was going to treat just his prostate and give him hormone therapy, I would radiate his prostate first and then give hormone therapy afterwards.
So, you are not waiting for growing PSA, just like adjuvant.
Yeah, no, radiate the prostate, like 7 treatments. And when the last treatment is over, I give the hormone therapy. Because this randomized trial tested. There's 300 patients in each of these groups. And if you look at prostate only radiation, and with the median follow-up of 14 years in surviving patients. So these curves represent death due to any cause, including heart attack, stroke, everything. Progression-free survival included death due to any cause. But with a median follow-up of 14 years in surviving patients, if you look at prostate-only radiation with adjuvant hormone therapy, it's pink. And prostate-only radiation with neoadjuvant hormone therapy is red. And these are different, statistically different, with a better outcome if you gave the hormone therapy after the radiation. Most people don't realize that, and they classically give what they call, what's called neoadjuvant hormone therapy before the radiation. But this is the only trial where we tested the sequence to see whether the sequence matters, and the sequence does matter, and it's better to give it afterwards.
I'm sorry, I want to receive more information. It's for all group of risk patient?
No,
or
no, 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 no. So if you
just
treat
all?
the pelvic lymph nodes, it's better to give it before.
In this case. Okay, thank you. It was
Yeah,
very.
so for high-risk patients, you should give it before. But if the
Mhm.
patient is only going to have their prostate treated, for some reason, it looks better when you give it after. These are the data. Okay, I
Mhm.
don't know how to explain it exactly, but I have ideas of why it might work that way. But these are the data.
Very interesting. Thank you.
Ludmila, do you
Okay.
have more questions about this SBRT case? You can just read them.
I want to open my slide.
Mhm.
One second. What specific aspects of CT simulation should be considered for this patient?
Are you sharing a slide? I don't see it.
Okay, second. Do you see my slides?
Yeah.
Second question, what you can recommend, what CT simulation you can recommend in the case of SBRT? Should we use 4D CT or maybe ABC or abdominal compression if the case we don't have a fiducials?
No, because how is abdominal compression going to help you in this case? I mean, you should use some type of image guidance, whether it's cone beam CT to line up the prostate or fiducials. And it's a trivial. I mean, if urologists can do biopsies where they take 12 or 15 cores, they can take 3 needles
Mm,
and put them in the prostate.
mm,
And then you can very precisely deliver your radiation. It's more important than IMRT or SBRT, is being able to accurately track where the target is. I'd rather, if somebody said, okay, you need to get your radiation in Ukraine, and you got 2 different doctors. One doctor has IMRT and the other doctor has 3D, but the one with 3D, they have a urologist that's going to put the 3 gold marker seeds in my prostate. I'll take the 3D.
mm,
Because the 3D is going to make sure that every day before my treatment, the treatment is going to look exactly like the plan, right?
mhm,
Pretty close. The IMRT, the dose distribution will be there, but it's not clear that the prostate is going to be where the dose distribution is. And there could be other normal structures in the way. So the bottom line is that I would want to use the fiducial markers under all circumstances.
Thank
In
you.
post-op, in anybody I'm giving high dose radiation to, because if you don't, when you use fiducials, you can make your margins smaller because you don't have to worry about motion of setup error, the patient, gas that day. I mean, we used to do that. We used to this is why we had 2 centimeter margins, 1.5 centimeter margins around people, 1 cm, 1.5, 2 cm for people getting 3D, because we didn't have image guidance to make sure that we are right where we need to be before treatment.
Yeah, nice advice. Thank you. What is your advice for omitting the rectal wall from the treatment field? There was some literature that we can make margins from the don't include the rectal wall in the PTV. What do you think about this?
Well, it's not, if you're gonna, this is kind of the same answer. If you know where the prostate is precisely before you give the treatment, then you know where the rectal wall is precisely.
Mhm.
So if you're designing it with very low dose to the rectal wall, the only way you can guarantee that is to make sure that every day before each treatment,
Mhm.
they put the patient on the table, they line them up with tattoos, and then they get out of the room, and then they line up the gold seeds, and they have the seeds from the digitally reconstructed radiograph, and they have orthogonal images, which are dead on right there immediately before treatment.
Yes,
And
we're
then
doing.
the margins, you can have tight posterior margins. So omitting the rectal wall, the only way you can omit the rectal wall is if you know where the rectal wall is, and the rectal wall is immediately behind the prostate. So if you know where the prostate is, you know where the rectal wall is.
Yes, in this case, we're doing everyday convinced CT, so we know exactly where is the wall.
Well,
But
you
yeah,
hope. I mean,
about
CT can be a little fuzzy.
Mm-hmm.
You know, that's the idea. That's the reason why people were looking at MRIs, because the MRI, the thing about a CT, if you go back to, there's a slide I had a slide where I showed CT. The first paper that was written that compared the prostate defined by MR versus the prostate defined by CT, I wrote in 1996. It showed that the prostate looks 30% bigger on CT than MR.
I remember that paper, yeah.
Yeah. So if you design a field using just CT, and then you put margin on that, if you put a bigger margin, now you're treating not only the prostate, but you're treating a bigger margin than you need. And because with the MRI, you can see tissue planes, you can see the rectal wall, you can see the bladder wall, you can see things better. And on a CT, it just all kind of blends in together, gray, soft tissue density. And so you can't define it quite as accurately. And if you aren't using fiducials to hit it, you need bigger margins because you're not adjusting for setup, for day-to-day setup margins. So then you have to reduce your dose. You can't give high doses if you're going to use big margins. And you can't
That's
use
right.
small margins if you don't have image guidance.
Right.
And what do you think about fusion with MRI scans?
We do it routinely when we do
Every
planning.
patient, we
Every
do
patient.
fusion. Yeah.
Yes, yes. Okay, thank you. And what we can use, when we can use SBRT for prostate cancer? In what group of risk you recommend to use SBRT? Because we try to use just in low group of risk this variant of treatment. What
Well,
is your
for the favorable patients, like favorable intermediate risk, I usually do SBRT monotherapy, no hormones, unless they have an unfavorable genomic score with Decipher or Polaris or one of those things. Otherwise, then I just radiate the prostate. If they have some unfavorable features, sometimes I radiate the prostate and give hormone therapy afterwards. If they're extremely unfavorable, intermediate risk or high risk, then I tend to give hormones before, treat the pelvis, and then use SBRT as a boost instead of doing HDR. But when I do that, I usually give the SBRT first. So I do a reverse boost. So I put them on hormones, I radiate the prostate with SBRT, and then I treat the pelvis.
Thank you.
Thank you so much. Excellent questions and answers.
Yeah,
I would like to encourage our audience to turn on microphones, cameras, and ask questions. Dr. Sokolowska.
Yeah, thank you very much, Professor Roach, for so informative lecture. And it was an honor to Ukrainian specialists to hear so much useful information. And I have a few, thank you very much, questions. First of all, it's considered about the oligometastatic disease when we have a few lesions, bone mets, for instance, and it's low burden, and what treatment strategy could be in this case?
So that's a good question. The question is about oligometastatic disease and whether it's low burden. The problem nowadays is that what is oligometastatic disease? I mean, and what's low burden? If you use the standard one that they use in the STAMPEDE trial and in the CHARTED study, the problem is that nowadays everybody gets PSMA PET. Now, you may not get them on all your patients, but that criteria was designed with conventional imaging. So what we don't know is if you have more mets with PSMA PET, should we use the conventional imaging to define whether the patient is suitable? So the Stampede study suggested that people with limited metastatic disease had a survival advantage with the addition of radiation to the prostate in addition to systemic treatment.
Yeah.
But it did not involve treatment of the Mets. They didn't radiate the oligomets. They only treated the primary. In my practice, if I'm treating a patient that has limited metastatic disease, especially if it's limited metastatic disease by PSMA PET, I treat the primary and I treat the Mets. I treat the oligometastases there. And that is because if you look at the Oriole trial done at Hopkins, where they looked at people with oligometastatic disease, they looked at what if you treat all the PSMA PET positive areas versus if you don't treat all of them, there was a big difference in the progression rate. So I favor treating the primary and treating the oligometastases, not just treating the primary.
So
And they
it
need
would be,
systemic therapy.
oh, sorry, it would be just filled for the prostate and separately for the mets in
Yeah,
bones, for instance, and it could be 60 grays in 20 fraction or
I wouldn't treat the
ultra.
bones 60 grand. I mean, in the Oriole study, they
SBRT.
used mostly 35. They used mostly 30 gray, like 600 times 5 or something like that.
SBRT, yeah.
Yeah.
Mhm. And for prostate?
Well, I do SBRT on the prostate. I'll do 950 times 4 or 725 times 5, and then I treat the oligomets, and then they're done.
Mhm.
In NCCN,
Okay.
an option to use 6th grade and 6th fraction with M1. Right? What do you think about this, Dr. Roach?
Well, in the US, we do
Right.
That's an
5 fractions.
insurance. That's an insurance
Yeah,
issue.
it's about a reimbursement situation. But I don't know why you would use 6 fractions for anything.
If
I
you
mean, you
can
don't
use
need,
5, yeah.
yeah. I mean, there's no evidence that 6 fractions is better than 5 and that there's a need. I mean, if he's got metastatic disease, he's likely to die of systemic disease, not local progression. If you look at the Oriole trial and other SBRT studies, 30 to 35 gray and 5 fractions, they have a 90-something% control rate. What you don't want to do is to cause complications by giving too much dose when you're doing palliative treatment.
Thank you. And I have a next question about transurethral resection. It's not the radical operation, and if patient has such type of operation, how we should to treat as a definitive or as adjuvant scheme of radiotherapy?
You're talking about a person who had a TERP for obstructive symptoms,
Yeah,
and
and
then
after
they're
that
and then
we
they're
have the radiation.
incidentally found to have prostate cancer after the TERP?
Yeah, that's right, yeah.
Okay, well, it depends on the patient. I mean, people that have had TERPs, they tend to bleed when you give them high dose radiation.
Mhm.
So I tend to cut back a little bit. If it's a patient whose prognosis is good, you can do conventional radiation. Sometimes I'll still do SBRT. It depends on how big the TERP defect is. If you have a large TERP defect, what happens is when they do a TERP, they scrape out the inside of the urethra, and that damages the blood supply to the urethra. So when you give high dose radiation, it calcifies and it becomes hard, and it can happen years later, like 5, 6, 7 years after radiation. And they also tend to bleed. So I've had patients that had TERPs who I treated who called me up from Europe when they were on vacation saying, Dr. Roach, I'm in Paris and I'm bleeding. And, so sometimes you need to dial back the dose and give them more of a conventional dose. Like we've never shown that high dose radiation makes people live longer, then don't make people bleed more. So you have to dial back. You don't want to be too aggressive in a patient who otherwise has a fairly good prognosis with conventional treatment.
Okay, so our decision have to be it's to provide radiotherapy, but in the definitive program like conventional fractionation or moderate hyperfractionation. That's
You
right.
could probably get away with moderate, but I think the safest would be like 70 gray in conventional radiation. I mean,
Yeah.
if it's a large bladder defect, I
And
think that it's a problem.
thank you very much. And I still have a question about pelvic irradiation. What indications for the irradiation of pelvic nodes, and when we can omit to irradiate it?
Well, I would not omit it if their nodes are positive, for sure. I mean, if they have PET positive nodes or bulky lymph nodes on imaging, they need to be radiated. Other than that, we don't have level 1 evidence that radiating the pelvic lymph nodes makes people live longer. So part of the justification for doing it is the pattern of failure. If you look at people who have high risk disease and you radiate only their prostate, they tend to fail in their pelvic nodes, but we don't have evidence that makes people live longer. So although I tend to treat people who are at risk, whose risk is greater than 15%, we don't have proof that people live longer because they have that done. Now, on our first study, 9413, there was a little bit more toxicity with pelvic radiation as reported by physicians. In 0924, we have twice as many patients and we have fewer complications because we're using IMRT. And so I think that if it's done properly, whole pelvic radiation is generally well tolerated. But in terms of the way you've worded your question, when would you definitely not exclude it? I would definitely not exclude it if I saw enlarged nodes. Otherwise, it depends, if the patient, especially if the patient had had small bowel, had bowel surgery or a history of diverticulitis with bowel adhesions or some other thing, and they were elderly and fragile, you may want to stay away from whole pelvic radiation because they might get a bowel obstruction. But otherwise, you're in a territory where we don't have proof.
Yeah, that's right. And actually the same question about adjuvant radiotherapy, when we have to do it and when we can omit, especially in case of
post-op,
post-op, and
well, I would treat,
Mhm.
unlike if you look at the Raves, Radicals, and JITIC 17 study, I would not offer it in a patient just because their pre-op PSA was over 10. I would not offer it just because a person has a Gleason score of 7. I wouldn't offer it just because they have a Gleason score of 8. But if they have seminal vesicle involvement or lymph node involvement, then I would offer it.
Okay. In local treatment
Well,
without
if they had, it depends on how many nodes they took. If they just did a radical prostatectomy and the patient's a Gleason 9 and they have seminal vesicle involvement, they didn't take all the lymph nodes, I would radiate the pelvis too.
Right.
Based on the sports study, which showed a better biochemical salvage control rate with pelvic radiation.
And
Yeah,
if
thank
we
you
have,
so much. Yeah, thank you for the questions and answers. I saw that
thank you.
there was one question in the chat. Thank you for the fantastic talk. Is any dose correction needed for patients with urethral catheter?
No, I mean, why do they have a urethral catheter? Because they're obstructed due to cancer, or they're obstructed due to BPH, or what?
It's not
If
clear
they're
here.
obstructed due to cancer, then you need to give them a high dose. I think those are good candidates for SBRT. Excuse me. If the patient comes in, they have bulky disease and they can't pee. We have a series that we published on patients that present with obstruction. So that would be, the ideal patient for SBRT. If they're obstructed due to benign prostatic hypertrophy, then they're not a good candidate for SBRT. Those patients, you need to deal with them carefully, because what you don't want is for them to become permanently obstructed. So people that have a high AUA symptom score or IPSS, the same thing, where they have trouble emptying their bladder, and that's because of an underlying physiologic flow rate issue.
Mhm.
Benign prostatic hypertrophy stuff, those are not good candidates for SBRT. But if it's tumor, then they are good candidates for SBRT. So you ask a guy, how long have you been having trouble peeing? And he said, about 6 months. I used to pee fine, and then now I can't empty my bladder, and I came in with a catheter, and the biopsies show 15 out of 15 cores are Gleason 9. Perfect candidate for SBRT, reverse boost. I do SBRT on the prostate, and you're frequently able to get those people catheter free.
Mhm. Yeah, that's great. Thank you. So there's also a question, do you treat 36.25 in 5 fractions? So that's the pace
Every other day.
fractionation every
Every other day.
other day. Yeah,
Yeah.
okay.
Yeah, usually it's Monday, Wednesday, Friday. Monday, Wednesday. Yeah.
How do you follow empty rectum, make an enema before every treatment?
No, when you're using fiducial markers, then you know where the prostate is all the time, and we don't routinely do it. But if you're not using markers and you're going to do SBRT, you definitely should be doing an enema. If you're going to
Okay.
do cone beam CT, it's not going to be quite as accurate. You need to use, I would do an enema, cone beam CT. Some people put them on a special diet, so low
Right.
gas
We put them
diet.
on the diet. Yeah.
Yeah.
Sounds good. There is also Dr. Safronova holding a hand. Dr. Safronova?
Dear Professor Roach, dear Ludmila Bordiuh, thank you for the excellent lecture.
Thank you.
Professor Roach, I can ask you if you give me an answer for the question about what do you think about nerve-sparing radiotherapy for patients in low risk and intermediate favorite risk prostate cancer in young patients who want to save their sexual function. Thank you for the answer.
Can you ask it one more time? So you're talking about bulb dose?
Excuse me?
You were
can
asking
you
me
repeat
about
the
the
question?
penile bulb dose?
Yes.
You asked me how low should it be?
No, I don't know. Maybe in young fashion, I have read about several articles about new ways the safe sexual function in young patients, nerve sparing radiotherapy, if we use SBRT, or if we use hypofractionation with no, in patients who have 6 or 7 Gleason, no, low risk and intermediate risk, if no, they want to save sexual function.
Well, okay, so the first thing is that you need to encourage the patient to be proactive, especially, in other words, if you should encourage the patient. Sometimes I talk to the patient and his partner, and I say radiation can compromise sexual function a little bit, and that I encourage them to be proactive if they need to use drugs like Viagra, sildenafil, whatever, if they need it, and to remain active. Because I tell them, if you don't use it, you lose it, right? So, but in terms of the technical aspects of radiation, is that you give the bulb as little dose as you can get away with while covering the prostate. So when we do SBRT, the penis is in a avoidant structure. We avoid beams that come from the bottom that go through the bulb. So we don't have beams going through the bulb. And by using fiducial markers, we know where the prostate is, so we can have a really tight margin below the prostate to keep the dose to the bulb low.
Do you also contour corporal bodies?
No, we
No.
don't.
We
We
contour
don't.
corporal
We
bodies
just we
also.
just we just contour the bulb.
Okay.
Even though, again, it's not the erectile mechanism, but
Yeah.
if the bulb dose is low, because of the way the prostate is set up, if the bulb dose is low and the prostate is above the bulb, then everything else at the level of the bulb is going to be low. You're not going to have high dose horns
Sure.
sticking down right here if you're using an SBRT, very tight margin
Right, right.
to spare the bulb itself. So you don't need to worry about the corpora. You know, there are people that claim that the corpora are the ones you need to spare. I don't know how you can spare the culprit without sparing the bulb.
We spare both. We try to spare
Yeah,
both.
yeah, right.
Okay, excellent. So really excellent lecture. Since you're a visionary, I'm gonna ask you a visionary question. So what is your prediction for the next, let's say, 5-10 years, how the prostate cancer care will change? And what would be the biggest contributor to the change?
Well, I think the studies that have been recently done, like PACE-A, like my trial when I get it published, the results are going to look so good that radical prostatectomy is going to be obsolete.
Okay.
But one area that we need to do more research in involves these biomarkers. And we're doing that, and there's some interesting stuff there. And then the other thing that we have to be concerned about is the risk of second cancers after radiation, which occur more than 10 years after the radiation. So when you're treating a 75-year-old man, you don't worry so much about second cancers 15, 20 years later. But if you're treating a 50-year-old,
Right.
then second cancers become a real thing that you need to worry about.
So what do you recommend then? Proton therapy?
No, I think we need more research on it. I don't think that protons, it depends on how the protons are used in terms of whether or not they can help you there. It could be that protons or carbon would reduce the body dose.
Right.
That
And
second
actually there was a
cancer.
study like that. Yeah.
Yeah, well, there's one
Michael
with
Shea.
carbon, but there are problems with the study design. Like, why did they get protons, and are they really comparable patients?
Right.
And
Sure.
in terms of the randomized trial that was presented at ASTRO, protons versus photons, the toxicity was the same.
Right.
So the question is the risk of second cancer is going to be the same? We don't know. It depends.
Okay,
You know,
thank
and
you so much. Yeah,
yeah.
so that was amazing. If people can turn on their cameras, we'll take a photo with Dr. Roach. That's a great opportunity.
Yeah, thank you, Dr. Roach, for interesting discussion. And
Look at those Ukrainians. It's quite nice to see them all. Amazing. It's dark in Ukraine.
yeah.
It's dark. I'm in Vienna, so it's
Vienna.
dark in
Dark
Vienna
there
too.
also. Okay.
Yeah.
Okay, we'll take a photo. So I'll do the count. Smile. Excellent. Oh, beautiful photo. I'll send it to you, Dr. Roach.
Okay. All right.
Yeah.
Well, good luck and nice meeting everybody. Sort of.
Nice to meet you.
Thank you
Ludmila, you
so
did a great
much.
job, and
Yeah, thank you.
Natalia,
Natalia, yeah.
you did a great
That's
job.
amazing. Thank you. It was an amazing lecture. Thank you so much,
Thank you.
Dr. Roach, for
Okay, take
teaching us.
care.
Thank you, Ludmila.
Okay.
Bye.
Yeah,
Okay.
bye-bye.
Bye-bye.
Thank you, Natalia, for organization.
Bye.
Bye-bye.